We are joined by Dr. Donald DiPette, who is the Health Sciences Distinguished Professor and previous Dean at the University of South Carolina School of Medicine in Columbia. He is also advisor to the Pan American Health Organization's Hearts in America's program, Hypertension Initiative. Today, Dr. DiPette will provide an introductory overview of landmark hypertension studies during the COVID-19 pandemic, practical clinical implications, which he will discuss in greater detail in his presentation taking place during SMA's Annual Scientific Assembly, October 26th through 28th in Greensboro, North Carolina. Thank you so much for being here today, Dr. DiPette.
Well, hi, Jennifer, and you're welcome. And again, I would be remiss if I did not thank SMA and the SMA family for allowing me to join you not only today, but also to present some of the topic that we're going to be discussing shortly at our annual scientific assembly, and again in October.
Well, again, we are just delighted you will be able to join us, and we can just jump right in if you like. And I would know our attendees as they're looking to attend this meeting. Why is this presentation that you will be giving so timely and important?
Jennifer, that's a good question, because at face value, you might think it sounds a little bit different. And it is different, because rather than discussing a broad-based topic of a disease state or pathophysiology or treatment, we're actually going to do something different. We're going to talk about individual studies over the last, say, 2 to 3 years on hypertension or its consequences and the clinical implications of those studies. So then I guess you got to ask yourself, why such a different format? And the reason is obvious. It's one thing and one thing only: COVID-19. Luckily and very fortunately, we're blessed to have come out of, or coming out or already been out of the COVID-19 pandemic. But it, as we all know, and I do not have to belabor this, it was devastating. And it disrupted all of our lives. It disrupted personal lives, family lives, community lives, if you will. But it also developed healthcare significantly. Again, not only health systems, not only even the education within healthcare, but it disrupted our communication. It disrupted our communication between physicians, colleagues, other healthcare professionals of the team, where we used to meet each other and we used to talk about things. And one of those things that are commonly talked about that we don't really think about is just discussing or talking about what we recently read and communicating those things in the literature, whether it's in the lay press or, better yet, in our leading journals. So that's where this idea and this concept came from, which is if there's been this disruption over the last 2 or 3 years, has that gone down to even the study level, where we've continued to publish, we've continued to do research, thank goodness, but have we missed, or has any of us missed some of those important studies that actually have dramatic or important clinical implications for our patient care? And when thinking about it for a little bit, the answer was yes. There have been significant clinical studies with new data, new information, new discoveries that could immediately impact our clinical care. And rather than just take it for granted that we all saw these either on an individual basis or a collegial basis, let's review them. Let's pick some, can't pick all, but let's pick some and go over those clinical landmark studies that, again, at a primary care and specialty level, directly will impact and probably will change the clinical management, in this case, hypertension. But really, this isn't just about hypertension. We could do the same thing with all disease states, because the pathology, the disruption of the pandemic was everywhere.
It was, and as you're talking and you're saying these studies are going to affect patient care, and as we look at everything and helping patients and the proactivity and things, why are these studies on hypertension specifically so important?
Well, first of all, I'm biased because in addition to being a general internist and a primary care physician, of course, most know that I've dedicated most of my academic career and clinical and research career to hypertension. So that is the answer to your question. It's because we're talking to me. On the other hand, it goes beyond me. Hypertension is the leading cardiovascular risk factor in this country and globally. And as such, it behooves us to pay attention to hypertension, treat hypertension, and manage hypertension. We have safe, effective, affordable, and available medications and lifestyle modifications that we know work. But here's the real reason we're talking about hypertension today and going to bring this to the annual meeting is because we're doing a dismal job at it. Despite all of these medications that we have, again, that are safe and effective, and lifestyle modifications that we know, again, I'll just repeat myself, work, we're not doing a good enough job. We are, even in this country, in a high income country, our control rates of hypertension, even pre-COVID, have actually been decreasing. We peaked at about 55% in the 2014 survey, if you will, of the NHANES data. But since then, it's actually gone down. And that's ominous. We should be treating and controlling everyone with hypertension, given the resources we have, the knowledge base we have, and the medications we have, as well as lifestyle modifications that we know work. So that is why the importance for hypertension, and to continue not only to talk about hypertension, but look at these new studies and see how and if they change our practice, which we have the solid goal and the one dedicated goal, which is increase the hypertension control rates to as close to 100% as we can. However you define hypertension control, whether you define it as less than 140 over 90 or 130 over 80, et cetera.
Not wanting to get too far off topic about studies, but you mentioned things that can be done, lifestyle modifications, medications. Why do you think our rates are so low? And are there specific reasons? Again, you don't have to go too far into that, but as it was mentioned.
Well, first of all, it's hard. Again, even though I said we have safe and effective medications, you've got to get these medications to the individual patient. So access to care is a barrier. They have to be affordable. And even though many are very inexpensive, et cetera, money is still money. So that's a barrier. Also, if you will, lifestyle modification is difficult. Even though I've said repeatedly it works, it's not easy. Losing weight, finding time to exercise, stopping smoking, and again, with the various other entities of lifestyle modification are hard. And even though best intentioned physicians, healthcare professionals, and individual patients and families, it's difficult to do. However, that doesn't mean we give up. And that doesn't mean we don't stop looking for new modalities, new methodologies, new data, such as are going to be presented in these studies to give us not only hope, but also more armamentarium, if you will, to address these barriers, and then also to increase our hypertension control rates as close to 100% as possible.
Speaking, kind of coming back to the studies themselves, what are some of the clinical categories of these studies that you're going to be reviewing and discussing at the assembly?
Absolutely. Well, we can't discuss all the studies that were published, so we had to sort of pick and choose. Some of the categories that we considered were diverse and quite plentiful. We narrowed those categories down to studies that involve our population and a population-based approach to hypertension. Like, in other words, looking at everybody as a whole. So that is one category. The other category is that guidelines are very, very important in terms of directing us and giving us, again, the evidence-based best practices, if you will, on how to approach hypertension. So we're going to discuss, in addition to population-based approaches to hypertension, any new guidelines that were developed over the course of the COVID pandemic, which would be the last 2 to 3 years. And there are new guidelines that became available. Then we're going to get a little bit more specific. We've talked about lifestyle modification, but one of the categories is going to be cardiovascular risk prevention. Yes, we talk almost always about treating hypertension or treating the disease, but wouldn't it be better to prevent the disease in the first place? So that's why that category was chosen. Then we're really going to get down to the individual patient and individual populations and talk about pharmacologic treatment. What's new? There's not new medications, but there's new ways to use these medications in not only the time of day that they're prescribed, but also in combinations together, and using them as best in a population-based management in an algorithm or a protocol. Then it really gets into more health systems and our health system-based approach to hypertension. Even though the common pathway is a individual practitioner and a patient in that exam room or the emergency room or virtually or on that phone, really, we're all in this together. So one of the categories chosen was team-based care. It's becoming increasingly evident that individuals are obviously the foundation, but we take care of patients as a team now, and hypertension is no exception. And in fact, we've been lagging behind in a team-based approach in hypertension. Our infectious disease colleagues have known this for years, and we're just sort of getting the message. Then we're going to talk about disparities. There is no question that there are disease-oriented disparities on race, base, ethnicity, socioeconomics, geography. Hypertension is no exception to these. We have significant disparities in hypertension, not only detection, but also treatment, and more importantly, control rates. So that's why that category was selected. I'm going to look at some, certainly a landmark trial that specifically addresses disparities in care in our individual hypertension patients. And lastly, believe it or not, we're going to talk about pregnancy, something that is far removed from my subspecialty, internal medicine, but my primary care colleagues know all about pregnancy, as well as, of course, our OBGYN colleagues. And there's absolutely new information on how we detect hypertension during pregnancy and how we treat hypertension in pregnancy, particularly what level do we start treatment, and then what levels and what targets do we want to lower that blood pressure down to that has significant clinical implications for the newborn.
This sounds like this is going to be an absolutely fascinating presentation. Kind of touching on the studies themselves, could you give us a specific study that you're going to talk about as an example?
Yeah, and I thought about this because there's many studies within those categories that I just mentioned, but again, I guess I'm just going to give away my biases. It's so important, and we have data now that shows that we can overcome this entity, and that is racial disparities. There has been longstanding racial, ethnic disparities, particularly between Blacks versus whites, although that's not to say there's not disparities amongst other groups, including socioeconomics and geography. But clearly, we've known for many, many years that our Black individuals with hypertension have their hypertension sooner than comparable white patients or individuals with hypertension. More importantly, however, it's more severe. And the target organ damage from that hypertension process is greater in Blacks than whites. And those are the implications of stroke, myocardial infarction, angina, renal failure, et cetera. That's the beginning. We also know, however, that we're not treating or controlling our Black individuals with hypertension to the extent that we control white individuals with hypertension. Even though both are dismal, our Black hypertensive control rate is much lower than our white hypertension control rate. And again, I'm belaboring it because it's so important. There has been a very, very important study. I'm going to give this one away because of its importance. We're going to detail it more, obviously, at the annual meeting. But there was a study by our colleagues at the Kaiser Permanente healthcare system in California. Many years ago, they developed a program to increase hypertension control rates within their system. And they did it with a very organized, very standardized approach. And this was for everybody, their entire population. And that's been ongoing for about maybe 13 to 15 years with tremendous data showing that within years of starting this program, even a few years, if not months, they saw significant increases in hypertension control rates in their population of patients within the Kaiser Permanente system, up to 80 to 85% control rates of that population as a whole. More recently, they've been able to analyze the individual patients within that population, particularly as they relate to race and ethnicity. They reported several years ago that the control rates of different demographic groups within that population were similar, if not identical, in the 80 to 90% range. And that included individuals that were European Caucasian, Black, Hispanic, Asian, Island, Pacific, etc., as well as other ethnicities. However, they just recently published a paper that then looked specifically at the hypertension control rates between their Black individuals with hypertension and their white individuals with hypertension within their practice. Now, remember, this is a quality insurance improvement. That's a quality, a quality improvement process within their population, that everybody got the same approach. No one was different. And that's important because it was uniform. And they just demonstrated recently significant increases in hypertension control rates in their Blacks that almost equalizes the hypertension control rates in whites. There was still a small gap, but a gap of only 2 to 3% between the two. Now, no gap is good. We want zero. We want them to be absolutely equal and to be as high as possible. So there's still that little gap, but the national gap between our Black versus white individuals with hypertension control is 15%. That means that our Black individuals with hypertension, the control rates are 15% less than our white individuals with hypertension on a population-based data analysis. And they've narrowed that gap to only 2 to 3%. So we're going to really significantly look at that study, look at what they did, what were some of the key drivers that resulted in that tremendous improvement in Black hypertension control rates. And one of those drivers, I'm just going to give it away now, has been the use of a standardized protocol, a standardized algorithm that starts with 2 antihypertensive medications upon the initial diagnosis of hypertension. And these medications are from complementary classes. That was one of the keys. There are others that we're going to discuss, but that was one of the keys that immediately and promptly and rapidly resulted in increase in control rates in all their populations. This is not to say that whites were not improving as well. They were, but the Blacks caught up and almost equalized the whites within the decade of this data analysis and presentation that was recently published.
Again, kind of veering just a bit from the study aspect of this, you mentioned briefly, because you may touch on this in more detail at the meeting, but could you provide a brief overview of what may have led to those disparities? Just touch on that momentarily. Again, I feel like you may address that.
Sure, and we mentioned some of them, but I think it behooves us to talk about them again. And I've had numerous discussions with my major colleagues at Kaiser Permanente, and what did they attribute it to? What did they think? Because it was a large quality improvement project. There were probably multiple moving parts in the initiative that started well over a decade ago. But I think if they had to give you, 2 or 3 key, then we're going to call them, and they call them drivers. They call them clinical drivers of, in this case, hypertension control. What were these key drivers? One of them was the algorithm, using a common and system-wide algorithm that specified the medications, specified the doses, et cetera, in the whole population of their patients, not one targeted to Blacks, not one targeted to whites or Hispanics, et cetera, but targeted to the entire population. That was one driver. The second driver was within that algorithm or protocol, which I've already mentioned, but behooves us to mention it again, was to start with 2 antihypertensive medications in the initial diagnosis. We're so used to starting 1 medication, Jennifer. And then if the blood pressure is not controlled, we increase the dose. We keep titrating it to maximal, however long that takes. If they're still not controlled, we add a second drug and titrate that one up, and then the third one. By the time you do that, it's a year later, or even more later. Well, if you start with 2 medications, you titrate them rapidly, and we're going to talk about that, and you use complementary classes of medications that also address the racial differences in blood pressure control. That's a key driver to achieving these remarkable control rates that Kaiser Permanente has. Lastly, using that algorithm, in a rapid manner. In other words, you don't wait 3 months or 6 months to bring the patient back and check their blood pressure. No, and if it's elevated, titrate the medications up. They see patients within 2 weeks, at most 4 weeks intervals. So if you start with 2 medications at half maximal doses, and you titrate up at 2-week or 4-week intervals, in 2 to 3, at best 4 months, you're going to be at maximal doses of 3 antihypertensive medications right away. And that'll control 80 to 85% of our hypertension populations. And as their data shows, eliminates the disparities. This also gets into one of our other categories. One of their key drivers also, they will tell you, is team-based care, approaching it as a team. Once the algorithm is developed under obviously physician supervision, et cetera, they allow other professionals, healthcare providers as members of the team to titrate the medications per that protocol. And they bring that patient back for a blood pressure check independent of the practitioner or the physician. So this is how one of the ways they can do it in such a timely manner. And then obviously titrate the medications up if the blood pressure is still not at the control level that the system or the individuals deem is their target.
This is so interesting, and I feel like I'm learning just from this overview that you're providing. We've talked about studies, so I think I would be remiss if I didn't ask, because you've mentioned there have been so many studies and not all of them could be addressed. How were the studies that you're going to be presenting, and talked about, how were they selected?
Well, that was the interesting question. I mean, was it all going to fall on my shoulders? And and first of all, that would have been a disaster. And I probably wouldn't have been able to, I wouldn't have known all of them either. Again, I went through the COVID period just like everybody else, and certainly missed some. So first I did some introspection, I thought myself, but that was not where I wanted to end. There's other organizations. The New England Journal of Medicine has a journal called Journal Watch, which publishes and goes over new studies during the year, but also kind of uniquely at the end of the year, they look at some of the most important ones that their editorial board or their experts deemed were the important studies. And that's for all disease states, not just hypertension. And finally, there's also other organizations. The American Society of Cardiology has lists of what they think are important clinical trials, so they're not missed, and of course they are discussed, et cetera, by experts in their field. And then finally, I just asked my colleagues. I asked my colleagues here at the University of South Carolina. I asked my cardiology colleagues, my general internal medicine colleagues, my OBGYN colleagues for the pregnancy study, et cetera, as well as colleagues around the country. My colleagues at Kaiser Permanente, other experts in hypertension and cardiovascular disease medicine, as well as my global colleagues at the Pan American Health Organization. I asked them, from your perspective, what are some of the important clinical studies that were published within the last 2 to 3 years? And everybody contributed. Now, the bad news is I got way more. The good news is I think we did a better job. Have we missed 1 or 2 out there? Absolutely. And that wasn't the purpose, to be all-encompassing, if you will, because we wanted to get this information out and disseminate it as quick as possible. But I think with this team-based approach, if you will, to picking not only the categories, but then the specific studies within the categories, I think we've got most. We don't have all of them, and there may be others that are important, maybe not as dramatic, that we want to continue to look at and maybe discuss further.
Well, Dr. DiPette, this has been a wonderful conversation and an overview of what you will be talking about in October. And to our listeners, we hope you will join us in Greensboro, North Carolina, for Dr. DiPette's presentation on Friday, October 27th, along with the rest of our faculty who will be presenting throughout the assembly. If you would like additional information, you are encouraged to visit sma.org/ASA2023. Thank you so much. And Dr. DiPette, thank you again for being here today.
Jennifer, you're welcome. And I look forward to seeing the SMA family and also our participants And I can't wait for the discussion after these studies are presented, because I am fully expecting other participants to bring more to the table from their perspective that they deemed important.
We absolutely look forward to that conversation as well. And thank you again for being here today.
You're welcome, Jennifer.